Welcome to the Medical Home webinar series. This is the first webinar in the series of 6. Today's webinar will be presented by Dr. Robert Ostrander, President-elect of the New York State Academy of Family Physicians. Before we begin, a few announcements. This webinar series is supported by the Health Resources and Service Administration of the U.S. Department of Health and Human Services under the Genetic Service Project Grant to Health Research Inc., NIMAC. This activity has been approved for AMA PRA Category 1 credit. There is reciprocity credit for allied health professionals, nurses, physician assistants, and nurse practitioners. The required CME accreditation is included in the slides and handouts. Instructions on how to obtain a CME certificate of credit is also included in the attached handout. So if you look at your GoToWebinar control panel, you will see 3 handouts attached in there, which are available for download. This live webinar will take approximately 1 hour and will be recorded. The recording will be available at a later date. As soon as the webinar concludes, you will be asked to complete an evaluation survey. Please take a few minutes to provide your feedback. Your input will help us in planning future activities. Participants claiming CME credits, please use how to obtain CME credits instructions handout to access your evaluation survey link and complete it and claim your CME credit. All other participants, please complete the evaluation survey that follows after the webinar. There are no conflict of interest disclosures or off-label discussion to announce. At this stage, we would like to acknowledge all our colleagues. We thank all our speakers and participants of the Medical Home webinar series for their contribution and participation. Should you choose to ask questions or comment, please use the question box in the webinar control panel to submit your questions and or comments. We will cover as many as time permits, and responses to the remaining ones will be emailed later. On that note, we are pleased to invite Dr. Robert Ostrander, President-elect, New York State Academy of Family Physicians, to present this webinar on practice team huddles and why they are important with a brief introduction. Dr. Ostrander.
Thank you, Kunal. I'm happy to be able to do this. I've been looking forward to it for some time. I think it would be helpful for those who are attending to understand my background a bit so that they can put my remarks and observations into context. I have been in private practice in a small rural practice in upstate New York doing full spectrum family medicine for about 20 years. Some years ago, I was invited to be part of a national learning collaborative on medical home for children with special health care needs, and that is how I got involved ultimately with NIMAC and the Secretary's Advisory Committee on Heritable Diseases nationally. Full spectrum family practice, like I do, is obviously not all just children and youth with special health care needs, but after 30 years in practice, I also have a fairly large population of older adults who have complicated medical problems and that require a lot of forethought and care coordination, and it turns out that the processes involved in providing good care to these two populations are actually quite similar. So I think some of the lessons I'm going to share have to do more with caring for my multiple medical problem adults than for children with special needs, but I do think that they're probably applicable across the board. I'm going to share with you some of my own experiences, and part of what I want to illustrate today is how the evolution of team huddles and processes for practice transformation need to be customized to fit the practice setting. You can do the next slide, Kunal. So the learning objectives for today are to recognize the value and some of the goals of practice team huddles, and we'll talk about those in some more detail. to describe some approaches for initiating team huddles in your practice, and discuss the ways that team huddles can make clinical practice more patient and family-centered. And we'll expand on each of these, I hope, as we go forward. Next slide. So, what exactly is a huddle? Sometimes I have problems with the jargon that is promoted to deal with practice transformation, but I actually like this word a lot because I think it conveys the experience that you're hoping to get out of this practice. When I envision a huddle, I think not so much of what I see at the Super Bowl, but as what I saw as a kid playing backyard football. A bunch of folks on the same team getting together, scratching their heads and deciding what they're going to do over the next minutes to seconds and how they're going to deal with what they encounter in order to accomplish their goals. So I think going in with that sense of a huddle will help your team function as a team. I think we found it very helpful in formulating our initial approach to team huddles to use the questions that we probably all had in our journalism section in 11th grade English, and that is to think about the who, what, where, whoa, go back, when and why of this activity. And obviously the big barrier is the big question, which is the how. Now you can go next slide, please. So let me start with talking about the how to do this. It would be nice if there was an instruction diagram. It would be nice if there was a stepwise flow sheet, but really developing huddles, and for that matter, much of what we do in practice transformation is not a stepwise process with a roadmap and checkboxes as much as it is an evolution. What I mean by evolution is really much of what we experience in patient care. You decide what needs to be done and how you're going to attack it, and then you step in and start to implement that, but always keeping an eye on what the response to the change is and modifying as you go and fine-tuning. It really is as much art as science. I mentally picture this process of practice transformation as thoughtful and deliberate molding and shaping of what's happening. That's an ongoing process. The other part of evolution is the drift and degradation that happens over time with any process, and part of thinking of this as an organic and evolutionary process is to monitor for drift that has degraded the process and be ahead of it, so you don't find yourself suddenly saying, what happened to when we used to do this awesome thing? I will use my practice as an example periodically as I go through this with you. And this notion of evolution, I think, lends itself to and suggests that the short cycle change, or PDSA process, is a useful way to get huddles up and running and have constant improvement of those huddles. Go ahead and let's have the next slide. I'm going to digress, and I'm sure many of the folks on the webinar have had training experience and exposure to the PDSA process or short cycle change process, but I think it's worth digressing and having me give you some of my perspectives on this because I think it's so important for this particular activity and that people have a sense of familiarity. The process, as it is often taught and adopted institutionally, can be very formal, and honestly, sometimes I think the formality of it gets in the way of its utility. So what I want to focus on here, and what I would encourage you to focus on going forward, is not so much using a PDSA template, unless that's useful to you, but rather using the concepts embedded in short cycle change to bring about what you need to bring about. Of all the things that we've done in our practice for practice transformation in the last couple of years, I think that this PDSA short cycle change process has been more important to this than to anything else we've done, really. Go ahead, next slide, please. So let's briefly talk about the parts of a PDSA, or Plan, Do, Study, Act cycle. When I was first exposed to this in a learning collaborative all those years ago, the first slide is one that I think people see a lot, is how do you change the tire on a bicycle and still ride the bicycle? And that's what any kind of transformation or improvement in practice is, because you can't stop seeing patients and can't stop taking care of people to do what needs doing. And so you need a process that's not going to be too disruptive to that. The plan portion of Plan, Do, Study, Act cycle involves a few things. It clearly involves, after looking at what your goals are, planning what your change might be. But it also means thinking about and anticipating how that might play out. It means anticipating what you hope to get out of it. It means anticipating how it might cause problems. It means being open to unanticipated benefits and harms when you implement things. The do portion, let me go back to the plan for a minute. The other part of planning is thinking ahead to the study portion and exactly what it is you're going to look at when you get to the study portion. The second part, when you actually implement it, it's very important that beforehand you take a measure of how things are, whatever it is you're trying to improve, how things are, so that you can make a comparison. And this is not a statistical research study. It means, it can be qualitative. It can be just an assessment of people's perceptions and attitudes. But take a snapshot of where you are. Right up front, you're going to do whatever you're going to do for a limited period of time or number of patients, and it needs to be a bite-sized chunk of time. For us, much of what we've done with this have been in 1- and 2-week increments. And then you're going to stop and think about it, and that's where the study part comes in. And I think the study part is often the most important and sometimes overlooked. A lot of times when people are doing these, they simply give it a thumbs up or thumbs down and then implement it. I think it's really a time to sit down and talk about, did we achieve what we wanted to? Was it manageable? Did it make our lives better? Did it make our patients' lives better? Were there unanticipated consequences? Were there unanticipated benefits? And how can we tweak it to build on the benefits and reduce the downside? And that then becomes really the plan of your next cycle, of course. And then the action, unless you feel like, yes, we've got it cold, the action really just becomes your next do. And this is what I really meant by an ongoing evolutionary process. I think it's important, as I said at the beginning, not to get bogged down in the process and necessarily have a formal PDSA template, but rather stop periodically and talk and kind of have a huddle about your huddles, essentially, using these concepts. Next slide, please. So, as you're thinking about implementing team huddles, or really any process improvement or changing things in the way you do things or in your practice, I think it's worth this taking stock of things that you might want to do differently. And I really think there are 3 different general categories of reasons we want to change things. One is inspiration, and I think those of us who are passionate have this happen all the time. Wouldn't it be nice if? Wouldn't it be awesome if? And so that becomes goes on the list. Imitation. We've went to a webinar or talked to someone or saw another practice, or were a patient ourselves and saw that somebody was doing something in a terrific way. And I want to spend just a second on the imitation part of this. Because it's a double-edged sword. It's very nice to be able to adopt what someone else has done and has worked well, the notion of published best practices are terrific, but it's real important that when you're using imitation of someone else's process in your system, that you think about customizing it, and that's a lot of what the PDSA cycles with imitation tend to be. I think a lot of times, internally or externally, we get forced to try to crowbar what looks like a best practice into something that doesn't work just right for our particular situation. And so when you're thinking about imitating something, think about customizing. I think a general concept that's worth touching on here is that there is great value in reproducibility and consistency of processes and the way things are done, because it reduces error and it reduces work. But the dynamic tension there is there's also value in personalizing and customizing things, whether it's patient care for an individual patient with diabetes, or whether it's how you set up team huddles for your practice. So I always try to bear that dynamic tension in mind when I'm working on processes. And then the last thing, and this has gotten to be certainly a big enough one, and it's according to the literature with burnout and all, it's getting to be a bigger and bigger one, is irritation. What is it that annoys me every single day when I'm going through this process, and is there a way to mitigate that some? Or, are there certain unavoidable irritants, like, compliance with certain processes that we're forced to comply with that we don't see value in? Is there a way to get that done but mitigate the pain that comes with it? So bear those things, I think, in mind as you're sitting and saying, how do we want to set this up? What do we want our why to be? Next slide. So what gets in the way? And this, I think, goes back to why I like the PDSA cycle. Why don't we change things? Inertia. We've been doing it this way. It gets in the way of riding the bicycle, and we're not going to do it. Well, if you make it bite-sized, it's less onerous. Too much weight given to Murphy's Law. And then there are people in every organization who look at any suggestion or process for change and say, oh, but what if, or this is certainly going to happen, and then so we're not going to bother because it could go wrong, or it probably will go wrong. The nice thing about PDSA cycles is if it goes wrong, it only went wrong for 2 weeks, and you can not do it anymore. Too busy. Likewise, this breaks it up so that it's something you can, much easier to find time in your day to make a small change for a couple of weeks and then look at it than to redesign your whole system. And then lastly, the enormity of the task. We want to get from A to B, and boy, but that's just too much. Well, let's just take a step and start with the lowest hanging fruit. By the way, I think it's an important issue when you're doing these process improvement things to set yourself up for success the first couple of times, especially. Next slide. So I'm going to take the who, what, where, when, and why questions out of order, because I think why has got to be the first thing. And this comes from one of the references that did some studying of this. And I'm going to read it. Most members reported participating in team-led huddles when asked in surveys. That is 85% of people. I don't like the word team-led just because I don't, but I don't know if that's a literature-wide word or just related to this study, but we chose to call ourselves a pod instead of a team-led. Anyway, a minority of the participants, however, described routine huddling, focusing on pre-visit planning that included all members. When members reported routine team huddling, they included pre-visit planning, so that's one of the whys, strategizing treatment plans for patients with special or complex needs, and I think that goes to one of our early objectives, which was how can we make our care more patient and family-centered instead of disease-centered. C, addressing daily workflow and communication issues through collective problem solving. Ensuring awareness of what team members do and what actions are happening on the team and then the practice. Primary care providers, interestingly, were the least likely to report routine huddling, and one can speculate all the reasons that might be. I think D is actually quite important. I think sometimes we can work together for years and decades and really not know what the other person's day is like. I think understanding each other's day engenders empathy, respect, and admiration, and bringing that into the dynamic of the practice setting makes things better for patients and makes things better for those of us who have to devote all of our time and energy, blood, sweat, and tears into taking care of folks. So it's interesting. I don't know what to make of they have huddles, but they don't do anything. It makes me suspicious that huddles happen, and I'll talk about this in a minute, because somebody said you should be doing huddles, and that always is a concern. However, the primary care doctors that did report huddles felt they were more efficacious in doing medical home, and all huddlers thought the teamwork was better and the practice environment was more supportive. And that's really important. We focus on our patients all the time, and we should. We're generous, forward-looking folks, but we need to take ourselves into account, and our team and our coworkers into account, because if the climate is not good, burnout ensues. And again, this is becoming a major health issue among physicians, and I'm sure other healthcare providers as well. And the barriers are fairly obvious. Not enough time, the system isn't in place, and they didn't write money, but money's always a barrier, isn't it? Next slide. So this huddle template was suggested by one of the authors in a pediatric practice, and again the references at the end. And it again addresses, I think, the question of the why. Well child checks, checking to see if there's been a well child check within the past year, looking at the next day's schedule, and making sure that enough vaccinations are in the office to meet the needs, looking for special accommodations for who might be on the schedule that day, and you can read the rest of the list. Procedures, checking patients for the next day, equipment, staffing, messages and faxes in baskets, and then there's a place at the top for the date and the time and who's present in the clinic, who's present in the huddle, and what the needs for the day would be. And one approach to this is to generate a document every single day. And for some people that will work best, and for some practices that will work best. For others, it becomes yet another checklist burden to do. And my experience with checklists and documents is that they often become the goal rather than the tool. And I think anytime we think about using any kind of tool, whether it's the Huddles as a concept or checklists for preventive services, we need to constantly make sure that the tool is serving the practice and the patient, and that we don't become servants to the tool. And that I think honestly happens a lot, and for various reasons that you can all sympathize with, I imagine, with the complexities of patient-centered medical home, meaningful use, and so on. Next slide. This is hugely important. If the why this is being done is to comply with another PCMH, meaningful use, or other metrics, the process will be painful, the benefits minimal, and the harm to care, team morale, and satisfaction significant. This is from unpublished experience of my own, but I've been involved with some student projects where they have tried to, in the practices where they were spending longitudinal primary care time, help set up team huddles. And some of the feedback in the study portion of the PDSA cycles has been, this feels like something we're doing because we're expected to do it. And if that's what it feels like going in, if that's what it feels like during implementation, it's not going to achieve nearly what it could. Next slide. So when we sat down and said, what do we hope to get out of team huddles? we wanted to improve the time spent with a physician. I looked at, and then we kind of all looked at what happened in typical examinations with patients with multiple or complex problems, and realized that I was spending a lot of time looking at my computer screen, and patients will tell you this is a terrible problem now with EMRs, looking at my computer screen, sifting through to find out when they last saw their cardiologist, and what did that CT that the oncologist ordered show. Yes, I got my lab work done 2 weeks ago, but it's not in the chart. Updating some things that could have been done by somebody with less education than myself in terms of filling in, family history and social history. So one of our main goals, and we tried to focus our process on this. I mean, make it patient-centered, make it about the care experience. One of my main goals is so that the patient and I could work together on the things that were important to us, and I wouldn't be distracted and drawn away by things. Related to this, make the flow of the visit smoother. And again, this sort of came out of the same analysis of what's going on. I'm in and out of the exam room saying, can you send for that test? We haven't talked about the fact that maybe I would have liked something done either before the visit or on the way into the exam room so that the flows were smoother. And then really linked to this is improved visit preparation. So we're thinking ahead of time about what we might need. We wanted to enhance team-based care and make it less disjointed, and that was really a huge benefit for us because I have a great group of a small pod, the three of us that do most of the patient care for my patients. But now that our roles are more clear and designed day by day, it feels even more like they're our patients and not my patients. Making the visits more personalized, patient and family centered, and that can happen if you take time ahead of time to say, this person has these chronic conditions, and we're going to do these chronic condition management protocols for, whatever it is, diabetes, asthma, action plans, and so on. But also, these are the things that are unique. And if you give that something that's just a matter of thought, not even a plan, but just taking a few minutes to think about it before you're in the exam room and being, bombarded with all the stimulation that comes from that, it allows you to design a truly patient-centered instead of a disease-centered care plan. This is a huge one, and I hope it's a goal for everyone, and that is reducing the number of things that are overlooked. Labs that should have been done or haven't been received, vaccinations, prevention things, chronic condition-related tasks, annual echocardiogram, and so on. And on the other side, avoiding duplication, because there's no reason that I need to order the same tests that my consultant just did 2 days ago. So these were our goals going in. Next slide. So I think it's worth, when we're all talking the same language here and trying to be part of a big national transformational process in healthcare, to think about how these goals fit the triple and quadruple aim. I think everybody's heard the word triple aim. I think some people understand it in way more depth than I do, and some just kind of know the word. And I think many now are starting to hear the word quadruple aim as well. And that fourth, I'm going to start with the fourth and go back to the initial three. But the fourth one has to do with improving the care team satisfaction and how very important that has turned out to be, and how very deleterious to care team morale chasing the first three has been without considering the fourth, because grinding down the people that are taking care of folks really destroys their empathy and motivation and energy, and makes them burn out and not do as well and retire earlier and all sorts of things. So I think it's becoming a consensus that the things that we do to do the first three, you have to also make sure they fit the fourth, or they're not really doable. So how do our goals fit the triple aim? The first one sometimes is stated as better quality of care, sometimes it's stated as better population health. Pick one very simply. If we're using Huddles to go through our list ahead of time instead of in the middle of a busy visit to find out who's up to date on vaccinations and whose chronic conditions need assessment, like hemoglobin A1Cs for diabetics, and providing, on the better care quality side, providing personalized care. We're meeting that aim. Better care experience. Well, we talked about that at the beginning. If the time with the office and with the provider can be relatively spared distractions, that's going to make the care experience better. If the visit from walking through the door to walking out of the door goes more smoothly, that's a better care experience. Lower cost, the obvious one is avoiding duplication. But in general, when you have some quiet time to think, and you're not trying to think on the spot, on the fly in the visit, you make more efficient, better plans for patients. Next slide. So, who's in a huddle? And this is got to be very specific, I think, to your situation, your patient population, your resources, and just your practice setup. So, potential participants in the huddle, maybe the physician, advanced practitioner member of the team, nurse, the receptionist, social worker, mental health provider, if that's integrated in your practice model, care coordination manager, if you have one. So you need to think ahead of time where to start with that. And, it shouldn't be a club that people are excluded from and vice versa. But it's concentrated time, and it should be small enough that it's not unwieldy. So we thought about all these things, and my practice, again, is a small rural practice, and we have more than one office in these small villages, and I rotate back and forth between a couple. You want to go back to the slide on the who?
Yeah, sorry about that. Just give me a second.
So our practice is a small rural practice, and we have small offices in some small towns, and rotate back and forth. So we don't have our care manager with us all the time. We have one for the practice, and we don't have the advanced practitioner that works with my team with us all the time. So we started with just the three of us, physician, receptionist, and nurse. And our first PDSA, if you will, for this was to huddle at the end of every day for the next day, all three of us. And we did that for a while, and it was cumbersome in a couple different ways. And again, not that I want to spend hours on the specifics, but I think it's worth me talking what we went through so that you can kind of be thinking about those same approaches as you set this up. So we did it for a week or two, and then did our study portion, if you will. And there were some issues. The biggest one is at the end of the workday, I often have a lot of physician-specific tasks that I need to do, phone calls and so on and so forth. And also, the last patient of the day is often someone that's somewhat complicated. And once I'm in there, there's not a lot that the nurse and receptionist necessarily would have to do. So they were waiting for me to get through my day. We were all exhausted. Everybody was going to be home late to dinner. And it didn't turn out to be terribly useful. It didn't offset that. We had talked about, and I'll get into the when later on, we talked about doing it at the beginning of the day, and there are reasons we didn't. So what we settled on, the next thing we tried was, well, really, in terms of setting up the flow of the next day, my nurse and secretary have been with me, receptionists have been with me forever, and they can anticipate almost everything. And so they huddle while I'm tying up my loose ends at the end of every day. And one day a week, at this point I'm leaving a little early on Friday, one day a week we huddle for the whole next week. And then I do an electronic, solo huddle, if you will, each day, and just, glance at things, and anything that pops in my head I may bring to them. So that's what we settled on, and it's worked out well for us. But what we did the first time didn't. It was very stressful, and it was causing a lot of just exhaustion and irritation. So that's what we settled on, and I think you have to be flexible and find the right pod size or huddle team that works for you. Next slide. So what do we do? What do we do in the huddle? Well, one thing is you can have a templated checklist that you actually a piece of paper that you go through with your huddle every day, like the one I showed you. We've adopted not to do that. However, there's a standard checklist that we each kind of have for each patient that we look at to see if there are any of those issues. We just don't fill it out as a piece of paper each time. It's just a reminder not to overlook things. So what we have done, and I think what typically is done, is you look at everybody in the schedule and make sure you all agree what the reason for the visit is and what tasks are going to be part of that. And then maybe typically look at the visit before, if it's a chronic condition kind of visit or a wellness visit, to see what was ordered last time and see if it's all back. Search for what's missing. And then this is the richest part of it for us, is we share some insights about the patient and family, because patients are very, very different in what their expectations and their approach to things. I mean, some people, you give them a review of systems checklist and there's a check in every box, and other people who are equally have the same medical condition don't check any boxes. And sharing those insights ahead of time are helpful. Talking for a minute about which patient is likely to bring a family member along to that visit to see if we could treat them at the same time. We know who those folks are, and anticipating that ahead of time, and making allowances, if you will, and getting a sense of what the timing and the flow of the day. Where am I going to run behind? Where do I have catch-up minutes? Maybe we should schedule this a little differently. Maybe we should tell this person to come in 15 minutes early because they're always 15 minutes late, and so on and so forth. And really do a mental rehearsal of the day, the three of us together. Let's see. Stay back one more minute, if you would, Kunal. Let's see, what was I had one more little point. Let me collect my thoughts. So I'm going to give you an example. So if we see a day that we've got a bunch of folks, either the schedule is really tight, or we've got a bunch of folks coming in who often bring an additional list of things either for themselves or family members, we have a letter we put up on the wall that we call our busy day letter. We put it in each exam room on the wall, and we decide as a huddle team whether we should be putting up the busy day letter tomorrow that just asks people if they're there for an acute visit, that we're going to have to focus on that and reschedule for additional things. And that that helps with the workflow and helps us feel in control sometimes when otherwise we might feel very out of control. And that's, again, one of the goals of this whole process. Next slide. When? Well, I talked a little bit about this before in our practice. I'm not going to dwell on it. But these are kind of the options. I mean, some people huddle before each session, if there's a morning and an afternoon session. Some do it daily, some do it weekly. Different times of the day are better than others, depending on what your phone situation is like, what your patient situation is like, what your staffing hours are like. But it's worth, number one, picking one, and number two, when you study after the first cycle, saying, was that the right one? And don't be afraid to change it if it didn't work out. Don't just throw your hands up in frustration and if the timing didn't work out, if that was one of the issues. So the when is maybe more important than it might first meet the eye. Next slide. Where? This is pretty important. This is concentrated work. I mean, you've got a lot going on in your heads, and you're really drawing a pretty complicated picture as you're going through this. And it needs to be a place where someone's not going to interrupt you unless it's really bad, really important. Where you're not going to have to keep stepping out of the huddle to answer the telephone. And it also needs to be a place where there's some privacy, because it's not that folks are going to say disrespectful things about patients, but you have to be able to be candid about patients who are often irritated, because there are folks like that, or patients who are very needy, and you have to be able to say that without saying it in code to each other in the huddle, so that you can figure out how you're going to address that and how you're going to help everybody through those more difficult encounters. So that's, and as I say, it goes to the where, but it also goes to the when, and that's why we ended up doing it at the end of the day. Even if we tried to do it at the beginning of the day, despite the fact that we're technically don't turn the phones on until 9, stuff happens right out of the box, either from the person on call the night before or whatnot. And at the end of the day, once the phones are over to the on-call person, we really do have some protected time where we can work. So that's why we chose it, and it's the time. So both the time and place need to provide a setting that's conducive to the things I just spoke about. Coming on to the home stretch here, right before questions. Go ahead, next. So, to summarize, start by examining your goals. I think is the right answer, and try to have that not be to comply with somebody's mandate. Examine the questions that we talked about. I would start with, again, the why, which is really the goals, and then spot out the who, what, when, and where. Make that part of your plan. Part of your plan is to study which of those things worked and didn't, and be open after you've implemented this for a couple of weeks and sat down and thought about it again. Again, I like the concept of a huddle about huddling. That you would modify, any of the who, what, when, and where, and then modify. Continually keeping an eye on this, and periodically say, how are the huddles going? Have we lost something? Are we inspired or irritated, or did we see something that we can imitate that we might want to move forward? So I'm done talking. It's been about 40 minutes. That's plenty of time for me to talk, and I'd be very interested in questions, but actually also comments and observations and practices that some of the listeners have heard. So I'm going to kick this back to you, Kunal.
Thank you, Dr. Ostrander. We have a few questions. I'll read it out to you. First question is, what does PCMH stand for?
Okay, I'm sorry. Patient-centered medical home. It's a certification, I think that's their word for it, that the National Committee on Quality Assurance gives to practices based on attesting to meeting criteria across several different domains, and it is required for participation in certain programs. It's achieving patient-centered medical home as a primary practice is required for enhanced reimbursement in certain programs, and some of the biggest requirements, the hardest ones to meet, are around practice transformation and so on. And an awful lot of practices have found themselves, their time and energy and emotional energy focused on achieving this designation. That's the word, it's not certification. Achieving this designation, and it's contaminated a lot of the potential benefit, at least in my opinion and experience. But the short answer is patient-centered medical home is a specific designation.
The second question is, children with severe disabilities may have many different pediatric specialists involved with their care. Can you comment on interdisciplinary huddles across different practices?
Traditionally, huddles have not been considered. That's not been considered what a huddle is. It's really something that's done around a specific clinic session. And there are a few places that offer interdisciplinary visits, although I haven't been specifically involved in those. In general, the care coordination, which is what I call what you're talking about, the care coordination piece has been done as a function of the care planning, care plan development at the patient-centered medical home. In other words, more commonly in our practice, if things are done well, a big chunk of the patient care plan is a list of the various problems, a list of the consultants that are involved in those problems, and a list of what the timetable for various consultations and tests are, and a list of who's responsible for addressing both management stuff and acute illness, acute symptom management. And so rather than that having been done typically by a huddle, that care plan is distributed to everybody involved in the patient care and the medical home, making sure that everybody's on the same page. If other people have experience with folks truly huddling before a visit across disciplines, and I would hope that you would maybe submit that to Canal, and maybe we can distribute it by email to all the attendees, because I'm not familiar with that.
Sure. Thank you, Dr. Ostrander. And as Dr. Ostrander suggested, should you have any resources, materials to share, please respond to the email you received about the registration, and we will compile those resources and make it available to all attendees. The next question is, I am a care coordinator and I work at several sites. While I appreciate the need to individualize to the pod, but I have difficulty with different teams doing different things, what do you find a happy medium with expectations?
In this setting, I mean, what I would hope to see, and we with our care manager, the part of what we do at our huddle is decide what to get the care manager involved in. But and this is actually an issue we have a big deal in our practice. I think it would be useful if you have a lot of care coordination needs in the practice. For instance, one option is to have the care coordinator across several pods huddle periodically, whether it's weekly to look at the week's schedule, or with a certain pay list of high utilizer, high need patients, to huddle periodically with the whole team. And a lot of times, I think the care manager, care coordinator can be the negotiator of what works best if it's done uniformly, and what makes sense to allow the pod to do the way that works best for them, or their physician or leader's specific approach to things. This is the problem I talked about at the beginning, about the dynamic tension between reproducibility and best practices on the one hand, and making sure we do something that people are comfortable with and fits their individual cultures. And our care manager has really stepped up and been actually the go-between among the pods, because she's the biggest person that we share that deals with the kind of issues that are so important at huddles. So I'm afraid what I'm putting on your shoulders is, I think the responsibility for having that discussion with each pod is actually best managed by the care manager, and then it becomes kind of a negotiation. They may not agree that everything should be done the same, but our experience we have now four pods in my practice, if you will, and our experience has been that there's been slow, steady coalescence around the most key things, and a lot of it that's happened since we brought on a care manager.
Okay. The next question is, what advice can you give to practices where the provider will not huddle with the staff?
And we have one provider who's a little reluctant. Ideally, it would depend a little bit if this is a single provider practice. I mean, that's very difficult. If it's a single provider practice, then the person in the team who's got the best relationship, can gently but firmly encourage it, and sometimes you can only do what you can do, and you may just get permission to huddle without them. In a larger practice, I think peer pressures is probably as helpful as anything. If you have buy-in from the majority of your providers, there are ways to, subtly suggest that be put on the agenda of however the providers meet from time to time, or decide how things are going to be done. And especially if it's done in a positive way. I mean, this is pretty typical human interaction stuff. But if it's done in a positive way, where the people that like it can tell the other people, why a person or people, how it's made their lives better and how it's made the staff happier. I think that's the best way to do it. So if again, the short answer would be, if it's kind of a siloed situation, find the person on the team who's got the best relationship, and give it a shot. If it's a bigger practice where there's a group of physician peers or provider peers, and you've got significant buy-in, try to informally and gently get that on the agenda for doctor-to-doctor, provider-to-provider discussion.
The next question is, how many PDSA cycles have you gone through with the huddles in your practice? That is the number of times you huddled about your huddling, as you called it.
5. Very close to that. I mean, I'm not positive it's exactly that, but we've probably had 5 iterations of this. And the last few have just been tiny little tweaks. Honestly, it has not been. I mean, the first one was obviously, the first PDSA cycle was huge, and the second one involved, significant changes of time and who, and then after that, it was just a matter of, fine tuning who was going to, I'll give you an example. I mean, maybe the third one or so, when it came to, I'll tell you, the third one, what we decided is when it came to wellness visits, that we were going to build, the nurse was actually going to do, was going to build the framework of the note, start the note before the patient came, usually the night before, and fill in the note all the consultant visits and so on and so forth, bring in the problem list, which again, made my time with a patient richer. And then actually we built on that with the next PDSA cycle. I'm glad you asked. This is a good example. That went real well. And we built on that with the next PDSA cycle to start doing that, not just with the annual wellness chronic condition visit, but then also with the intercurrent chronic condition visits too. And so again, I would say about 5. But the last 2 or 3 were nice little. Again, once you build it, then you shape and mold it. I've been little shaping and molding ones.
The next one is, we have 5 providers and none of them will huddle. I think it's a group decision with them. It's more of a comment.
Say again? I missed the first part.
We have 5 providers and none of them will huddle. I think it's a group decision with them. I think it was a more of comment. Okay, yes, and that is a frustrating problem. I mean, I think those of us, and this I'm going to put on my vice president-elect of the academy hat here, the State Academy of Family Physicians hat. I think a lot of the reason I'm involved in this, and some of us are, is to
is to move these things along. Anybody who looks at a change in adoption, I mean, there's a whole theory around it, but there are what they call innovators, early adopters, late adopters, and so on. And if you've got a practice full of late adopters, you hope they don't get dragged into a kicking and screaming because somebody forces them. Because as I said, I don't think that's a very helpful thing. But sometimes that's just where you are. And this is not something that these kind of changes never get adopted wholesale through the healthcare system, whether it's team huddles or screening for breast cancer or providing penicillin to kids with sickle disease. There's always a process, and it's frustrating if you would be inclined to be an early adopter and the providers are late adopters, but it's worth understanding that there are such things, and that even the late adopters usually come around. Ultimately, if something is indeed worthwhile, there's usually only a very few people who draw the line in the sand at the end.
We have time for one more question. Question is, have you ever had an outside observer monitor the huddle to offer suggestions for improvement?
We haven't had anybody monitor them from the outside. We do have we're participating in a practice transformation grant, which is how we started out with our care manager. And we haven't had them monitor them, but we have reviewed the process with them. The suggestions that came from that were suggestions to use, more formal PDSA forms and more formal templates and checklists. And as I told you, that's at least our culture. That doesn't work very well for it and made it feel more onerous. But that was honestly the main suggestions that came out of it. As things have gone forward and the outcomes are better, the organization that's consulting for us has been more open to the fact that the process elements can be flexible if the end result is achieved. And it's interesting. I mean, there's a growing literature actually in medicine that shows that small, privately owned private primary care practices have the lowest cost, lowest hospitalizations in many, many arenas, and they're relatively process light. So that there's starting to be an awareness that the process is like Goldilocks and the Three Bears. It can't be too much, it can't be too little. It needs to be just right.
Thank you, Dr. Ostrander. We see some hands being raised by the participants. If you could kindly add your comment or question in the question box, we will make sure to compile and summarize the responses and to be made available to everyone. On that note, I would like to thank everyone for participating. A few more announcements. Thank you, Dr. Ostrander, for practical implications of the practice team huddles. Just a quick reminder for CME credit access and information, please refer to the instruction handout that is attached. The slides are also attached as a handout. You will be prompted to complete an evaluation survey after this webinar. Kindly take a few minutes to provide your feedback. We really appreciate your input in planning future activities. For more information, feel free to contact us at the given contact information, and also refer to the Hopkins CME website for more CME activities. On that note, once again, I would like to thank everyone for a wonderful webinar. Thanks, Dr. Ostrander.
Thank you, Kunal. Thank you, everybody, for coming.